call you again. Sorry about that.
Okay. Save. Thank you. Oh, perfect. Okay. So just to talk about competing interests and acknowledgements, I have worked for a long time and continue to work with vaccine companies because I'm interested in vaccines. I've done advisory boards for Sanofi, Securus, AstraZeneca, and Pfizer over the last 3 years. During SARS-CoV, I served as a consultant to the Ontario Nurses Association and the Elementary Teachers Federation of Ontario related to workplace safety. And this is the work of many different people, colleagues, colleagues, postdoc students, and so forth, and funded by Canadian Institutes for Health Research. So for the most part, I'm an epidemiologist, and this is if you could boil epidemiology down to one sentence. There's a wonderful quote from a guy, Raymond Greenberg, who says, fundamentally, this is about the idea that disease doesn't occur at random. We can find patterns that allow us to link exposures and outcomes. And when we understand causal paths between exposures and disease, what we can do is we can then intervene and we can change people's destinies and make things that would have happened otherwise not happen. Hence the close tie between epidemiology and public health and prevention. Part of that, if we're looking at exposure and outcome, we usually do this with some variation of the form, look at exposure and outcome in an exposed group and look at lack of exposure and outcome in an unexposed group, and are they different? Most of epidemiology involves that. And for that to be valid, those comparisons have to be fair comparisons. So I'm going to present kind of two talks, which is why I'm a little anxious about time. Part one of my talk will relate to ascertainment. Actually, we're talking about this morning. Ascertainment problems when we do epidemiology of infectious diseases, and we differentially test people based on their outcomes. So these people are going to get sicker, so we'll test them more and find more cases. And then I'll talk about confounding, which is also called sort of collapsibility in epidemiology, and how that distorts our understanding of cause and effect relationships, and what tools are in the toolbox to solve that problem, but also what tools we can use but don't necessarily need to use all the time to solve that problem. And I'll use the term randomized controlled trial fundamentalism during that part of the talk to describe what I think has sort of emerged with an overemphasis on randomized trials. So what you see is what you test. This is the basic idea. Again, just like disease does not occur at random, the rest is commentary. This is the basic idea for the first half of my talk. This is summer 2020, Ontario, Canada, SARS-CoV-2. Are folks familiar with standardized morbidity ratios? So you look at incidence in a group divided by incidence in some reference group. It's very similar to a relative risk. So top is standardized morbidity ratio for infections by age group in Ontario for SARS-CoV-2. Second panel is standardized testing ratios, which we estimate in exactly the same way. Test rates divided by tests in some reference group. And the bottom is a standardized positivity ratio. So a proportion positive in our group of interest divided by proportion positive in some reference group. And in the top two panels, what you can see is there's a similarity. So in terms of standardized morbidity ratio, what do we see? We see most of our cases, our case rates for SARS-CoV-2 are disproportionately higher in older people, and they're quite low in kids and teens. But then if we look at standardized testing ratios, we see the same pattern. And so we see a relationship there. And the basics of this is published a couple of years ago now in Annals, what I'm going to be talking about. What does that tell us? How does that allow us to adjust incidence for frequency of testing? Because maybe we're just seeing more cases in old people because we're testing them more. And maybe we're seeing less cases in kids, not because kids are uninfectable, but because we test them less. So this is the basic idea, and I think this is one of the few little equations in the talk. This is the Annals paper on one slide. So we can set up a regression model. Regression is just, if you remember from high school math, y equals mx plus b. You all remember that, the equation for a straight line? Okay, so regression is that, where the b is the intercept, right? And the mx, and the m's the slope. That's what regression is. So linear regression, we have some data points and we're going to try and fit them to a straight line that has an intercept and has a slope. In a regression model, the slope is that thing beta, and the intercept is alpha. And what we're going to do is we're going to regress. We're going to say log of standardized morbidity ratios has some relationship with log standardized testing ratios, okay, by I, which is some age, sex, public health unit group. So these are strata, individual groups. Y log, before I was just talking about standardized morbidity, standardized mortality. Well, if we log transform these things, do you know where this is going? Well, it's at the bottom of the. But the cool math trick here is that if you have a referent group, which is the most tested group in your population, which in Ontario, Canada, through most of the pandemic, was women aged 80 and over because they're the majority population in long-term care facilities. What you're doing here is when your group, if it's, you know, boys 0 to 9 or women 20 to 29 or what have you, when that group is being tested at the same rate as women age 80 and over, your most tested group, the standardized testing ratio is 1 and the log of 1 is 0. So because we can just cross out a 0 term in this equation, that means that alpha, that intercept, is the standardized testing ratio, the standardized morbidity ratio for that group relative to 80 and over-year-old women, if that group of interest were tested at the same high rates as 80 and over women. Does that kind of make sense? So basically what we're going to do is this lets us do sort of the thought experiment. Well, what if we tested 10-year-old boys at the same rate we're testing 80-year-old women? Is a data-based way to say what infection rates would we see? Okay. And what we see, this is a figure from the Annals paper, is we see a very different epidemic curve. So the dashed line at the bottom is not an epidemic curve, but a distribution of cases by age. That bottom dashed line is cumulative case incidence by age in Ontario. And you can see it's anchored over at the right-hand side on test rates in older women, which don't change with this methodology because they're the referent. But what we see is we see particularly high adjusted test rates in young people, particularly young men. We see much higher rates in kids than we see in the absence of test adjustment. And there's a degree of face validity to see younger men as the most infected group. Younger men are overrepresented in workplaces that didn't get shut down because they were essential work. Abattoirs, we had some big outbreaks in commercial bakeries and mail sorting centers, our Amazon distribution center famously. Also, we know kind of from a survey research that younger men are were more likely during the pandemic to be disinformed about public health measures, more likely to be anti-vax, more likely to be anti-mask than other groups in the population, and less likely to comply with public health directives. So there's a degree of face validity to this. Well, what can we do with this? So these are our test adjusted estimates. Let me just look and see how I'm doing for time. So what we can do with this is we can start to reevaluate our experience during the pandemic in a way that allows us to get rid of these ascertainment effects. And we applied this to the problem of community mask mandates. Ontario, Canada, that's a map of the southern part of Ontario where most of about 90% of the population lives. Northern Ontario is about the size of France, and it's very sparsely populated. And for mapping, there's the whole provinces on the inset. The map, though, shows you the time in weeks since June 12th, 2020. The white region is Wellington, Dufferin, Guelph. It's a public health unit where the medical officer of health was a former pulmonologist who really understood respiratory stuff and instituted a mask mandate on June 12th. And the other health units followed suit with variable lags. This set up kind of a nice natural experiment on masking. And as you can see at the top, a group of health economists at Simon Fraser University in British Columbia said, oh, it's a natural experiment. We can study mask effects if we just look at what happened to infection rates with and without mask mandates. And they found modest effects of mask mandates, sort of 20% risk reduction. The difficulty is that what they were using were reported cases. So this is from a paper we published in a journal called PNAS Nexus. The bottom curve, again, is the official data, the official epi curve, cases by time. The blue curve is what happens if we adjust for frequency of testing. And what you can see is you have a much bigger initial wave than is appreciated for the first wave because we didn't have a lot of testing going on. The second wave also looks big, but actually looks smaller than the first wave once we adjust for frequency of testing. And this isn't from the paper, this is from the manuscript that got submitted, but not as easy to read in the paper. And if we look at, basically, if we attack this like Karavanov, like the economists did with a couple of different kinds of models, we do see these modest and not always significant effects of mask mandates. Then when we use test-adjusted cases, of course, the effects look much larger because we are adjusting for the fact that testing changed, and so apparent case counts changed over the course of these first couple of waves. So that's one application. And what we did with this is, some of you may know this trick, you can estimate population attributable fractions by just taking this regression model, which admittedly doesn't fit the data great, it's the blue curve, and then just setting the mask coefficient to 0. So the orange becomes the counterfactual, the world we would have seen if we didn't have mask mandates, and we can tabulate up the differences between those curves in terms of hospitalizations, predicted ICU admissions, healthcare costs, and so forth. So our estimate is that we probably saved about $610 million in Ontario with mask mandates based on health and economic gains. So that's just to December or so 2020, at which time masking policy became homogeneous across the province. The provincial level took over in setting policy. But now we have all these different waves, and you can see Alison McGeer and her gang came up with this admittedly somewhat arbitrary classification for pandemic waves in Ontario, where waves 1 and 2 are, this is initial emergence, this is that fall. Wave 3 was when the N501Y variants were out. Wave 4 was Delta wave. Wave 5 and 6 are Omicron waves. And you can see what happened to per capita testing over the course of the pandemic is extremely variable. Throughout the pandemic, women, this red curve here, tested more than men. And the most tested group over here, the females, for most of the pandemic was women age 80 and over, except in the summer of 2021 during the Delta wave, when there was a much more intense focus on testing kids, and boys aged 0 to 9 became the most tested group. So we're going to just shift which reference group we use. But if we concatenate, do this for all these different ways, and then concatenate into a test-corrected epidemic curve, it looks different. So the blue is the official epidemic curve in terms of cases, and the red is test-adjusted cases. So here's wave 1, here's wave 2, here's the bomb that, here's wave 2, here's N501Y. Excuse me, here's the bomb that didn't go off with the Delta wave. We really didn't have much infection there. We were testing a lot, so you can see there's no difference between test-adjusted and reported cases because we were testing a ton. And we were highly vaccinated. We had topped 80% of the population had at least one dose of vaccine. And then along comes Omicron. And unlike here, where it's sort of like this big explosion followed by damped waves, you can see that Omicron actually was at least 3 distinct waves. And at this point, our data get cut off. So that's where it ends. This is the death data. And what you can see is that, maybe I'll show it to you here. There it is. I'm skipping ahead here. There it is. And then I may back up. The death data in terms of looking at how cases versus adjusted cases predict deaths, because, sorry, I'm going to make you all vertiginous. This is our data on the lag from test positivity until death in people who died. from COVID. And what you can see is that it's profoundly right skewed. So it's something like, what was it? It's about 16, 17 days as a mean, about 12 days as a median. And then the blue dashed lines are the interquartile range for that. But it's a very right skewed distribution. So what we've done in terms of looking at the predictive validity of cases for death and adjusted cases for death is we've set up what are called distributed lag models. Have any of you come across those? These distributed lag nonlinear models. So what we do is, rather than, if we put cases at all these different legs into a model and we want 8 legs, we're going to have a ton of collinearity in our model because all these cases week by week are correlated with each other, and we're going to have big standard errors because we're over, I guess, specifying the model. We're putting in too many covariates. The workaround for this is we actually treat deaths. We create we create a case exposure risk surface, which is the lag of cases times the number of cases. So you can think of it as a 2-dimensional, basically like a grid. And we can put that in our model as a covariate. So the grid is a covariate. And that then gives us, and you have to make assumptions about the relationship between exposure and outcome. But that then is going to give us the ability to incorporate legs of 1 to 8 weeks into a model. And what we can see is actual deaths are the black circles. The blue is when we predict them with test-adjusted cases, and the red is when we predict them with crude cases. They both kind of work, but the blue works better. The adjusted cases are more predictive of death than the red cases, than the red crude cases, particularly during time periods where we didn't have a lot of testing. So that's a step towards validation. A second step towards validation that we're working on right now relates to wastewater testing. We had a wonderful wastewater surveillance program in Ontario that's unfortunately was defunded in the province about 6 months ago, which is a shame. But you can see that in terms of population coverage in the province, we're a province of about 16 million people. And we went from very few people covered in July 2020 all the way up to about 50% of the entire province being covered by July 2021. This again, these are the monitoring sites on a map. And what we should see with wastewater is we should see wastewater leading on cases. That's why we like to do it. We know there's good data from Alberta saying when they monitored long-term care facilities, individually monitored the outflow of wastewater, when wastewater signal spikes, they're going to have an outbreak in that long-term care facility. So we should see wastewater leading on cases. We actually don't see it for reported cases. It's backwards. You can see there's a negative cross correlation. For adjusted cases, you do see this nice relationship where when wastewater goes up, adjusted cases are going to go up 3-4 days later. And if we, again, do what's called a Granger analysis, this is econometric kind of forward and backward regression. So we've got lots of legs in this model, and just look at the predictive ability and the fit of these models, so that the AIC, which is sort of a summary of model fit and complexity, is lower for adjusted cases. The BIC is lower. The p-value, they both work, but adjusted cases work better. So the p-value is 10 to the negative 53 versus 10 to the negative 30. Okay, so we're trying to validate this methodology. So we've got deaths, we've got wastewater, now we've got seroepidemiology, because we actually have very good seroepidemiology for Ontario for much of the pandemic. So remember, young men, particularly in our study, in our initial test adjustment study, seem to be the most infected group once we adjust for under-testing. And in the Canadian Blood Services blood data, what do we see? Well, this is seroprevalence by date in 4 age groups that are available to us. The 60-plus-year-olds actually have the lowest seroprevalence. Next lowest is the 40 to 59s. Next lowest is the 25 to 39s. And the youngest folks in the blood donor data actually have the highest seroprevalence. So that doesn't jibe at all. That's the opposite of what we see in reported case counts. And what we're going to do is, oh, this is the second equation. Do not pay attention to any actual math here. What this is, so when we do seroepidemiology, and when I teach seroepidemiology, we usually treat it as this thing where it's a one-way ticket. It's like the Hotel California. You never leave. So you become seropositive and you're always seropositive. But of course, that's not true. People serorevert. And so you can actually think of seropositivity at a population level as being in a dynamic equilibrium. So rather than quote the Eagles, I will quote Josh Ritter. The sad thing with life, there's people always leaving just as other folks arrive. Seroepidemiology is like that. People are turning seropositive as other people are turning seronegative. So we need seroconversion and seroreversion in a model to model seroepidemiology properly. So this is just a compartmental model where we're allowing people to transition in both directions because seropositivity changes so profoundly, as you can see. With the onset of Omicron, we had very low seropositivity in Ontario until Omicron came along. And then it just sort of takes off like a rocket ship. We're going to model this separately for those two periods. And this is what model fit looks like. It sort of undershoots a little bit in the older people, but other than that, it's actually not a terrible fit. And what we can do is we can look at logistic regression-based estimates of risk using adjusted cases versus crude cases, and also this model to generate relative risks relative to the youngest individuals for the second oldest group, third oldest group, oldest group. And what we see is when we use adjusted cases, it's actually pretty coherent. This stuff hangs together pretty nicely, and we get the same results whether we use regression or whether we use a serologic model. When we try to do this with the reported case counts, it's just kind of a bit of a dog's breakfast. There's no coherence to it. So that's the first part of my talk is, you know, how do we take data that we know are distorted by over testing of individuals who are at highest risk of poor outcomes, and how do we sort of, this doesn't replace seroepidemiology clearly, but how do we adjust those data so we have a clearer picture of how risk was distributed across age groups. And again, this anchors on the idea that if all of these groups were tested at the same frequency as the most tested group, what would we see? We also, I glossed over something. Go back to it. I'm just giving you all vertigo. I glossed over this, which is actually kind of cool. What we see in our data, this is a logistic curve, and this is looking at the probability that the adjusted cases and the reported cases give us the same answer as a function of per capita weekly testing rate. And what you can see is that for most of the pandemic, Ontario was below this per capita weekly testing rate of about 5%. During the periods when we exceeded 5% of the population tested every week, which is an astoundingly high fraction of the population, about 16 million people tested every week, then these estimates converge. So there's no difference anymore. It's not useful to test adjust because you get the same answer, which I think is kind of interesting. So this doesn't replace seroepidemiology, but it gets us to a place where we can talk in a little bit more nuanced way about risk by age, by sex, by geography. And this can obviously be applied to other communicable diseases where the same thing applies. If I had RSV and influenza testing data, I would love to do this again for RSV and influenza, because I think we do tend to test more at the extremes of age for those diseases. I'm working with a marvelous postdoc at the moment named Clara Lee, who's doing this with some old pertussis data that we have. You know, you look at pertussis epidemiology, overwhelmingly the highest risk group is kids under age 1, but that's also who gets tested. And there is some reason to be interested in how much pertussis is there really in older folks because of the questions around how frequently should you boost and so forth. And we can also do this for Legionella, where we have the opposite, where most of the testing is in older people. And we see most of the infections in older people. Okay, so that's part one of the talk in terms of fair comparisons. Part two of the talk is part talk, part rant. So apologies in advance for rant. And who and what these guinea pigs are doing on my slide will become. Does anyone know whose guinea pigs these are? No, nor did I. We should know. So I'm going to talk about confounding, and confounding is a distortion that we see in epidemiology, where the relationship between an exposure and outcome is distorted or twisted because of some third variable. Okay, what I'm going to do is I'm going to talk about some old pneumonia work we did, looking at antibiotic choice and whether people live or die in hospital, and the question of whether that's confounded by comorbidity. So maybe people get different antibiotics when they're sicker or when they come in with, a history of being colonized with antimicrobial resistant organisms or what have you. Comorbidity may somehow be tied up there. And if we collapse the whole population together without regard to individuals' comorbidity status, we get what's called Simpson's paradox, which is you get a different answer in the pooled data than you get in the stratified data. Okay. So to confounding. First, I want to toot my own horn and the collective horns of my friends and colleagues. So we published this last year in Clinical Microbiology Reviews. It's something I'm really proud to have been part of. It is a sprawling and multidisciplinary evaluation of the roles of masks and respirators in preventing respiratory infections. It was led by the marvelous Trish Greenhall from Oxford. And among the authors, Raina does biosecurity as an infectious disease person. Michael Baker is a New Zealand public health person. I do ID public health. Amanda Kvalsig is an academic in Australia who's hearing impaired, because we were interested in the question around, masks and individuals who lip read. So she's there. Matt Oliver is an engineer. Mark Hungren's a biophysicist. Joe Vipon's an emergency room doc. And so I'm tooting my own horn here, okay? Strengths of our review. It's interdisciplinary. We integrated public health, fluid dynamics, policy, epidemiology. We included all available evidence. We addressed population level implications, not just does the mask protect the wearer. And we also, I'll show you this briefly, we critically reanalyzed a Cochrane review from 2023 that said not enough data to really comment on whether or not respirators are better than masks. Key conclusions: airborne transmission is the dominant route of transmission for respiratory viruses. Masks reduce transmission if they're worn correctly. Mask mandates reduce community transmission, and respirators outperform cloth and surgical masks. So contrast this review to the Cochrane review from 2023. I'll just read it. The pooled results of RCTs did not show a clear reduction in respiratory viral infection with the use of medical surgical masks. No clear differences between the use of medical surgical masks compared with N95 respirators when used in routine care. So there are a couple of issues here, and this is from our review, where what we've done is we've actually what Cochrane did is they just pooled all these studies together, regardless of how masks were or weren't used. Over on the right-hand side, what we've done is we've actually restricted the meta-analysis to studies where in randomized trials comparing masks and respirators, the respirators were worn continuously. Because putting a respirator on and taking it off is sort of like going out in a thunderstorm and opening and closing your umbrella and then coming in and saying, this stupid umbrella doesn't work, I'm still wet, right? If you're worried about a pathogen that's suspended in shared air, then use needs to be continuous. And what's interesting is Cochrane doesn't comment on heterogeneity. Their estimates are heterogeneous, but if we pool in this way, we get rid of heterogeneity and the results are consistent. If you pool these randomized trials together with randomized trials where people are using respirators incorrectly, you introduce heterogeneity and you come to the conclusion that, the estimates are all over the map and we can't say. Anyway, I don't want to get too bogged down with this, but there's a single data point in Cochrane for the assertion that that masks and respirators are equivalent for prevention of respiratory infection. They say no evidence of difference. The recently published lobe RCT conducted over a prolonged course in the current pandemic has provided the only evidence to date. So our review has something like 417 citations, I think, in the references, but this is their only data point. This is a partial list of the issues with the lobe randomized trial of masks versus respirators. Inappropriate use of the intervention, donning and doffing of respirators diluted the benefit, unplanned crossover between arms. So people in the mask arm were also using respirators. Inappropriately wide non-inferiority margin, which was noted by an accompanying editorial. Since when do we do equivalence trials where you have to be more than twice as bad to be considered different? Major protocol deviations, including different sites, changing in the analytic plan. Most of the effects that they saw are driven by mega recruitment from an Egyptian clinical trial site that was added in the last 3 months of a 3-year-long trial during the emergence of Omicron. Their protocol was revised post hoc after the paper was published and criticized, which it defeats the entire purpose of publishing a protocol. The per protocol sites in Canada and Israel, the Israeli site dropped out, the Canadian sites were stopped as they approached the threshold for non-equivalence. So you had a P of 0.10 for non-equivalence, they stopped recruiting. So there's some issues there. But here's what GRADE says. So GRADE says our starting point is because this is randomized, we have to regard it as high quality evidence. All the observational stuff, we start off as low quality, right? Because they're all observational. And that is because of the possibility that we could have confounding, measured or unmeasured in observational studies. So here's the thing. Overvaluation of flawed studies like this one based on their presentation as a randomized trial creates several difficulties for us. We overvalue the flawed studies, we undervalue other sources of evidence. We have the necessity of RCT, which drives kind of an RCT industry, where if you need an RCT for it to be admissible as evidence, you better do an RCT, even if it's not considered to be ethical in the country where you want to use your drug. And there's been some very, very explicit examples of that, and I'll show you one. So for example, we have offshoring of randomized trials, which wouldn't pass ethical review in Canada. They get performed in other countries. And prioritization of a constructed hierarchy, this evidence pyramid, over any kind of context, ethics, or scientific judgment. This isn't animating, unfortunately, there it is. So offshored RCT, this is from a group in Canada at McMaster again. Influenza vaccine to reduce adverse vascular events in patients with heart failure. We couldn't do this in Canada. It would be considered unethical because we strongly recommend that people in heart failure get their flu vaccine, because we know people with heart failure, if they get flu, are very likely to die. So what did they do? The study was done at 30 sites, mostly hospitals affiliated with universities or research institute in 10 countries in Asia, the Middle East, and Africa over 3 influenza seasons. In pre-specified analyses, the study showed exactly what you would have expected the study to show. And basically the reason why you didn't have equipoise ex ante is the people who didn't get flu vaccine and who had heart failure died more, right? So the first co-primary outcome, cardiovascular death, non-fatal MI or non-fatal stroke, and secondary outcomes of all-cause death, cardiovascular death, and pneumonia were significantly lower in the vaccinated group, which again is why we recommend influenza vaccine. So again, led by Trish, we tried to write an article during the pandemic about how evidence-based medicine needs to really become evidence-based medicine. We call it EBM plus. if you like that or don't like that. The idea is that there are a lot of different sources of evidence beyond randomized trials. This actually wound up on the cutting room floor, but Trish had this in an early draft, and I think it's great. This is referring to an article by David Sackett. It says the most quoted definition of EBM, the conscientious, judicious, and explicit application of current best evidence, occurs in the same paper as one of EBM's least quoted sentences. Evidence-based medicine is not restricted to randomized trials and meta-analyses. It involves tracking down the best external evidence with which to answer our clinical question. So it was never meant to be this way. It's never meant to be this way. And yet, this I think text was written by Matt Oliver, remember, the engineer. New engineering problems are addressed by creatively applying and actively improving existing standards and models. A bridge engineer doesn't need to design structural steel beams de novo. Bridge design doesn't involve building successive designs and testing each to failure or testing in a randomized trial before settling on an optimum design. Rather, many parameters can be determined analytically using numerical models. And the same is true in health. When we talk about randomized trials, we also have to be conscious of the history of human experimentation over the last few centuries, which has some very dark facets to it. Does anyone know what this is a picture of on the right-hand side? Where is that? I actually don't know which state that's in. Nevada or New Mexico, I'm not sure, somewhere in the Southwest. So these little round things in the foreground are the backs of people's helmets. It's a group of soldiers watching an above ground, I think it's an atomic test. I don't know if it's a nuclear test. And they don't know they're being intentionally exposed to high levels of radiation, and they're going to be followed as a cohort in the years to come so that we will understand the effects of radiation. They don't know that. So here's before we get to this in the question period and someone says, but can't randomized trials be useful sometimes? RCT are an extremely useful tool in clinical medicine, and in some cases in public health and economics as well. So I've said that, and I believe that they are very, very useful. But RCT aren't always feasible or ethical. The history of human experimentation reminds us why this bar is supposed to be high. Because RCT involved direct observation of participants, their utility for evaluating indirect effects, so for example, herd effects from vaccines, even if we cluster randomize, is not great. Most human knowledge and understanding doesn't derive from RCTs. There are other ways to know and understand our world. Now, this is my little jokey slide where I propose a randomized trial of how we're going to get across the, I think that's the Hudson River. Whether we should use the existing bridge or the trebuchet that I have invented. You know, I don't need to do this trial because I know what would happen if I put a car in the trebuchet and fired it across the Hudson River. And I can have a causal model about how that would play out without actually doing the trial. I already know based on my other parameters that I derive from my 50 odd years as a human on Earth. So I don't need to do that trial in order to know. Nobody did a trial to say you could fire a telescope into space and get these images. Nobody did a trial to say you could record light and radio waves coming from these distant bodies and understand their physics and how they were made and where they came from. There are lots of ways to know and understand the universe that don't involve randomized trials. And so this is a relatively recent, I speak with a fervor of the new convert because I am a new convert. This fellow's name is Judea Pearl. He's a computer scientist who came up with Bayesian networks. And if you don't think you know about Bayesian networks, you actually do, because if you're typing on your phone and your phone tells you what word you're going to type next and it's right, it's doing that with math inside the phone using Bayesian networks. So Bayesian networks are networks where the probability of something happening next is constructed using other available data points, using basically Bayes' theorem. He has a very dense book that I've struggled with and never really been very successful in getting through called Causality. But he also has an easy reading version of the same called The Book of Why, which has sort of become my new Bible. So Pearl went from Bayesian networks to realizing that you could apply these things using what he called do calculus to the study of causality. He managed to bring on board a pretty prominent epidemiologist named Sander Greenland at UCLA. He's at UCLA, or was it? He's emeritus now at UCLA, and Jamie Robbins from Harvard School of Public Health. And they kind of together figured out the framework for applying do calculus, or directionally cyclic graphs, or DAGs, to epidemiology. And this is about 20 years old now. So Pearl says that when we understand causality, and he's got a baby here because we understand this very early in our lives, we kind of get to the top of this ladder by the time we're about 3, that there are these different levels to our understanding of causality. The first is just correlation. We see something and we see something else accompanying it, and then we start to associate those things. The second level here is randomized trials. My cat does this. My cat knows that if he sticks his paw up inside the kibble dispenser and moves his paw around, sometimes kibble comes out. If he doesn't stick his paw in the kibble dispenser, kibble won't come out. He's doing a trial, and he understands what the effects are of that trial. My cat's a very smart cat, but I don't think he has any understanding of what the mechanism is that's allowing the kibble to come out when he wiggles his paw inside the kibble dispenser. The third level here is imagining. So what Pearl says is, if you really understand causality, if you really understand causal relationships, you can anticipate what's going to happen in a situation you haven't experienced before. Like, for example, if you fire a big telescope into space on a rocket, move it around so you can see things. This reminds me of a great quote from my late friend, a guy named Babak Purbalal, who was a prominent Canadian infectious disease modeler. Babak said, models lead us from data to understanding, and understanding allows us to predict and control. And my spouse says, we are all modelers. Not all modelers use math, which I think is right too. So these are just my course notes from Epi 1, or my course slides from Epi 1. What does a randomized trial look like in a DAG? I already mentioned this example. We're interested in, let's say, macrolide antibiotics and death. But we think people with comorbidities may be less likely to get macrolides, or maybe they're more likely to get macrolides because we think they might have Legionella. Doesn't matter. We think there's a relationship. And so when we study the relationship between macrolides and deaths, we may condition on comorbidity, stratify, use a regression model, what have you, or in a randomized trial, randomize to balance this between two groups. When we randomize, what are we doing? We're creating what Judea Pearl calls a backdoor collider. And these things have really interesting, you remember how comorbidity had an arrow pointing to macrolides and other measured confounders had an arrow pointing to macrolides. Once we randomize, once we have this upstream arrow pointing into the exposure, what we find is that these other paths get blocked. So when we randomize, what we're doing is we're creating a backdoor collider that blocks the paths between both measured and unmeasured confounders, and that's why we like it. But we can also use what are called instrumental variables that economists have been using for about 100 years now. I think they're introduced in 1927, where we find a variable that's associated with our exposure of interest, but is not independently associated with our outcome of interest. In healthcare, a common instrumental variable, I think we were talking about this last night in terms of variation in practice. Beth Israel and Deaconess, quinolones and aminoglycosides. Yeah, so health practice is incredibly tribal. People tend to do it the way we do it here because that's the way we do it here. I work now at a hospital where quinolones are like haram. They're the devil's, the devil invented Cipro. They really don't like Cipro, and sometimes Cipro is useful, but they look askance at you if you utter the C word. But that we can actually turn that peculiarity, that kind of idiosyncrasy of clinical medical practice. And I mean, there's the whole Dartmouth Healthcare Atlas that's about this, about variation in practice. That can actually become a potent tool for us. Because if variation in practice is associated with exposures, but not independently associated with outcomes, we can use it as what's called an instrumental variable. And as you can see, this is exactly the same as a randomized trial. So it's going to block these paths too, block the paths between the measured confounders and the unmeasured confounders. Okay, this is my timeline where I think I had an insight preparing this talk, which is I think the reason DAGs aren't in evidence-based medicine is because the EBM intense evolution happened between the 1980s and the early 2000s, which was exactly the same time that DAGs were evolving in a parallel discipline in computer science, and they just haven't crossed over yet. But let me show you quickly before I end an application of instrumental variable analysis. So as Keith knows, when many years ago now, I guess I worked in Philadelphia, and I worked at a teaching hospital that was owned by a big chain of hospitals called Tenet. And Tenet had done some interesting things and gotten in trouble with Health and Human Services. And part of their mea culpa, in addition to paying their fine, was they created this network-wide quality initiative. This is where Tenet hospitals were at that time. And we published a paper with my student, Caitlin McCabe, saying, you know, in our big data set from across all these different hospitals, we find that when people are prescribed antibiotics that are compliant with IDSA ATS guidelines, that is basically second, third generation cephalosporin plus either quinolone or macrolide, which is what it was at the time, they die a lot less. Here's the take-home odds ratio, 0.7 for death in hospital, lower odds of sepsis, lower odds of renal failure, reduced length of stay. And we thought, well, that kind of makes sense. That's why the experts recommended, you know, the recommended therapy that's in the guidelines makes sense. But some folks suggested that, you know, what we're seeing here is just all practitioner skill level, that the better doctors are better in lots of different ways. And the survival analysis, the guideline concordant therapy is just a marker for the fact that you had a better doctor who was keeping up, you know, getting their CME credits. I don't know. So what we can do is let's look at this. We're going to redo the analysis, but we're going to use geographic variation and guideline compliance as the guidelines were in the early 2000s as an instrument. And what we can see here is across all these hospitals, this is, I think, 111 hospitals, 107 hospitals, we can see that proportionate mortality is between 5 and 15%. So it varies by hospital. But there's huge variation in guideline compliance from 0% to 60%. So this looks like it might be an okay instrument. And when we rerun our analysis, we get the same result as we got before back, you know, 15 years ago. It's very protective odds ratio. When we do this is an instrumental variable analysis, we get a null effect. It's not there at all. It doesn't seem to be due to unmeasured confounders, where if we maybe spare this and see if anyone has questions about it, this large p-value suggests it's not due to unmeasured confounding. And then with instruments, you go through and sort of assess the strength of the instrument. TLDR, it's strong instrument. So to sum up, real world data provide us with a wealth of understanding in epidemiology. Messy data, we actually call our research group the data raccoons because we thrive in other people's garbage. We find it and we gobble it up. Messy data can teach us a lot if we let it. And we live in a data-rich world now. Biases and distortions make comparisons unfair, but we have many tools to deal with or at least understand potential implications and directions of bias. Conceptual models and DAGs, contexts from other areas of research and use of inference and imagination allow us to learn. Good epidemiology requires more than a checklist. Good epidemiology requires collaboration with and learning from epidemiologists. And then I'm very proud, I have to show you my extra slide because I'm very proud of it. I'm very proud of the graphic. I don't know if you get my little joke. That's all. Happy to take questions. I'm sorry, I think we've gone a bit long, but we have 5 minutes.
People, hi, David, that was excellent. Online people can either leave questions or comments in chat, or they can unmute. Any questions in the audience? Dr. Herrera. The mic.
Nice talk. Enjoyed
Thanks.
it. I'm gonna ask a question about part one, which is on the testing
Yeah.
model. And uh, I think you mentioned that you're assuming that testing was at the frequency which was done for the population of females over 80. And so I'm curious about that number that was fit into the model because uh, there's a lot of epidemiologic modeling that has been occurred, both modeling as well as in real world testing, sort of like the RCTs, which showed that if you increase the frequency of testing, you're actually going to decrease the number of infections that are occurring, hospitalizations, and deaths. So I was just surprised to see that when you increase testing in the young males, that you still see such a significant bump
Right.
in.
But that's data-based. So what we're seeing is the way that equality is set up, we are seeing that relationship. So the higher the standardized testing ratio goes, the higher the standardized morbidity ratio goes. So that's infections in that age group, whatever it is, young men or what have you, relative to infections in the reference group, which is mostly older women. So we actually do see that relationship. That's what we see in the model, and that's why we can, X out that coefficient for the standardized testing ratio, because we see that relationship, and we see that intercept giving us, when we apply it back to older women based on that relationship, which is observable. Like that's where the estimate comes from, is from the data. When we apply that back, that's how we get these very high estimates. So it's not assuming a huge amount of testing. We're kind of somehow testing every last 20 to 29-year-old male. It's simply extrapolating out from a relationship that's already there in the data. And that's, of course, why the validation part of this is so important, is seeing, okay, does it actually predict death better? Yeah, it seems to. Does it have a stronger relationship with wastewater, which wastewater obviously doesn't know whether we're testing men or women or young people or old people? Yes, it does. Does it look more like the seroprevalence data? Yes, it does. So that's the importance of the validation part.
I'll ask one more quick question on the seroepidemiology part. Both the seroconversion as well as seroreversion. I think that works well for an infection like SARS-CoV-2 or COVID-19 and other respiratory infections. But for example, in the case of the flaviviruses, you're thought to have long-lived antibodies. So I was just wondering, in a model like that, would that parameter just be excluded from the model because you don't serorevert?
It could be, and a lot of seroprevalence models, I mean, I didn't invent kind of seroprevalence models. So usually what you do is, it's, as I say, the one-way ticket. The Hotel California seroprevalence. People will sometimes have, the little added bells and whistles for, for 6 months of life in terms of maternal antibody to correct for that. But yeah, as you say, this is important for SARS-CoV-2. It may not be important for other. I don't know if it's important for measles or not. The estimates are derived via fitting. So it's sort of maximum likelihood based in terms of the balance between those two things, because you could imagine there's probably multiple solutions where you lower them both a little bit and you get to the same place. So it's kind of a fitting problem. Yeah. What's interesting, what I didn't mention, is seroreversion actually looks fastest in the older people. I didn't show you the parameters that we fit for the models. So the seroreversion parameters aren't the same across age groups, which I think is interesting.
You would have fun looking at yellow fever data, because yellow fever maternal antibodies are passively transferred to the infants, but the infants have antibodies for about 4 months and then they revert. Whereas the mothers, it's a one-way ticket.
Let's do it.
Yeah.
For real.
Yeah.
Questions? Sorry, I think they just said that how great Dave was, but you can look at his chat. I had one question. If there's not online chat, I don't know if you know how to look, but I'll ask my question while I check. So we had a grand round speaker. Oh, wonderful presentation. Good job. We had a grand round speaker, Ryan Shields, who lectured to us about observational data for antibiotics and how there's randomized controlled trials that'll never get done. Like they published, he and Jason Pogue, the cactus, which compares ceftolozane tazobactam to ceftazine-avibactam for pseudomonal infection. And no one's ever going to do that randomized
Right,
controlled trial.
right.
Pip-tazo versus cefepime for pseudomonal pneumonia will never be done, right? So he was making the point that we need to get past, if we want to move forward, that we need to find creative ways and try to minimize bias using observational data.
We're
And
saying,
you-
we're saying the same thing.
Right. So it
Yeah.
applies, I think, in the antibiotic world a lot too. You
Abs-
mentioned that a little bit.
Absolutely. I actually have an instrumental variable because, remember the black box warning with cefepime? 20 years ago, there was this question, there was a meta-analysis of cefepime RCT that said, oh, it looks like there's more all-cause mortality in cefepime arms than cefepime RCT. You see that in these data. And when you do an instrumental variable analysis, the effect actually gets stronger rather than weaker. But this is one data set out of, thousands and thousands of data sets that are around. And I think what's neat about this is we could use this tool in medicine. Like it's, geographic variation in practice really is an incredibly useful resource potentially. And this isn't hard to do. I mean, basically the way you do this mechanically, I don't know if there's any like data nerds in the crowd, but all you do is you do logistic regression once to predict the antibiotic exposure. You estimate what the model residuals are, and then you do the same logistic regression over again with the antibiotics in, but also the residuals. And what that's basically doing is you've now got a covariate in your model that's adjusting for the degree to which you misclassified people as being on that antibiotic or not. I mean, that's all there is to it. You do two logistic regression models instead of one. It's not rocket science. If it was rocket science, I wouldn't be able to do. Yeah.
Thanks very much, Dave. This is an excellent talk.
For sure. And thank you for having me.
Hey, Bobby. Dang it.